Procedures of the session to you, sir.
We have not been supplied with the speaker's name.
So we'll just forward it to you. We have the CV displayed. You can see, sir. I'll send the details. Yeah.
So, let me invite Dr. Saurav Kumar Das. I'm happy to see him again in this forum. And he is presently working in Max Super Specialty Hospital, Shalimar Bagh. He has done his PDCC critical care medicine from Department of Anesthesiology, Institute of Medical Sciences, Banaras Hindu University, Varanasi. So his area of interest is translational research, antimicrobial resistance, critical appraisal of the research papers, and systemic review and meta-analysis. He is very enthusiastic worker and keen researcher. He has published many good papers. So I invite Dr. Das to continue with his topic.
Thank you, sir. Good morning, everyone. First of all, I would like to convey my sincere gratitude to the Department of Anesthesiology of Urban Hospital for giving me this opportunity to interact with this young and budding anesthesiologist. The topic of my class is Basics of Mechanical Ventilation. I would like to start with a simple question. What do you actually mean by ventilation? Is it oxygenation? Is it to remove carbon dioxide? Is it both oxygenation and to remove carbon dioxide? Or it's also to protect the airways? If someone asks me to increase ventilation, then what should I do? I will increase either tidal volume or the respiratory rate or the both. And if I do an ABG after that, what will I see? I will see decrease of partial pressure of carbon dioxide, and there will be no or little change on partial pressure of oxygen. And if someone asks me to increase oxygenation, I will increase either FiO2 or PEEP. So in a ventilator, there are some parameters to increase ventilation and to wash out carbon dioxide, and there are some parameters to increase oxygenation. So we all know that gas moves from high pressure to the low pressure. During oxygenation, oxygen moves from alveoli to the blood as the partial pressure of oxygen is high in alveoli than the blood. And during ventilation, carbon dioxide moves from blood to the alveoli as the partial pressure of carbon dioxide is more in blood than the alveoli. So we can see here the movement of gas during oxygenation and ventilation, it happens in opposite direction. To understand mechanical ventilation, we have to understand three basic concepts. One is elasticity, one is compliance, and one is resistance. Ventilating alveoli is like blowing a balloon. When you find a balloon difficult to blow, we call the balloon is elastic. Elasticity is a property of a substance that tries to retain its original shape. And when you find a balloon easy to blow, we'll call it compliant. Resistance is offered by either the air resistance or the tissue viscous resistance by lungs and adjacent tissues and organs. Air resistance is due to gas viscosity, the gas density, length and diameter of the tube, and the flow rate of the gas through the tube. Apart from the diameter of the tube, all other factors, they remain constant during mechanical ventilation. The diameter of the tube may be altered by increased secretion, bronchospasm, or the kink of endotracheal tube. The resistance can be calculated using the following formula, that is peak inspiratory pressure minus P plate divided by flow. We can take help of this diagram to understand the effect of compliance and resistance on ventilation. The uppermost diagram is of lung with normal compliance and resistance. The original tidal volume is 500 ml and it expires 300 ml of tidal volume in 1 second. When lung is less compliant, it will have less tidal volume, so it will expire it will expire in less time. But when this lung has a normal compliance but high resistance, it will expire in longer time than the normal lung and the lung with low compliance. The product of compliance and resistance is called time constant. The concept of time constant has come from the decay of radioactive materials. We can use here during expiration also. Time constant means in constant time, a constant volume will be expired. For example, a patient with normal compliance and normal resistance, it will expire 63% of the tidal volume in 0.8 seconds. So if he has tidal volume of 500 ml, after 0.8 seconds, 170 ml of tidal volume will be left in the lung. In next 0.8 seconds, another 63% of tidal volume will be expired. So 58 ml of tidal volume will be left. Then in another time constant, that means after 3 time constant and total 2.4 seconds, the lung is almost completely empty. So during expiration, at least we need to give 3 time constant, that is 2.4 seconds for expiration. It is important because inspiration is an active process and expiration is a passive process. We can alter inspiration by increasing tidal volume or the pressure, but expiration we cannot do anything other than giving adequate time. So we know that gas moves as according to the pressure gradient. So two pressure gradients are important in mechanical ventilation. One is trans-airway pressure. This pressure is required to negotiate airway resistance, and the transpulmonary pressure. This pressure is important because it is required to ventilate the alveoli. How to calculate this pressure will come a bit later. What is the function of ventilator? The function of ventilator is to simply push air in patient's lung and let that air comes out. When you push a certain amount of volume over a certain amount of time, we get flow. And when you push this volume in a closed chamber, we get some generation of some pressure. This volume, flow, and pressure, they are used for ventilation, for oxygenation, and also it has to be controlled that there is no injury to the lung. So we'll see now how a ventilator control volume, flow, and pressure. This is a diagram of inner circuit of Dagger ventilator, and this diagram looks quite complex. So to understand, I have made it a bit simple. So here we can see fresh gas source, inspiratory valve and expiratory valve, and patient lung. When inspiratory valve is open, gas comes from the fresh gas source to the patient lung. And when expiratory valve is open, the gas goes out to the atmosphere. The process of opening inspiratory valve is called trigger. After delivery of preset amount of tidal volume or the pressure, the inspiratory valve is closed. The process of closing of inspiratory valve is called control, target, or limit. Then expiratory valve is open. The process of opening of expiratory valve is called cycle. The expiratory valve can be opened either by time or by change of flow. When it is opened by time, we call it time cycle, and when it is opened by flow, we call it flow cycle. Sometimes inspiratory valve is closed and expiratory valve is yet to open. This period of inspiration is called inspiratory hold or pause, and this is helpful for better oxygenation. So modes of ventilator are actually the way we open and close inspiratory or expiratory valve. So we can describe the modes of ventilation as per TTC. TTC matlab T for trigger, T for target, and C for cycle. We have learned that when inspiratory valve is open, we call it trigger, and it can be open either by change of flow, change of pressure, or in some certain time interval. Inspiratory valve is closed after delivery of some volume or pressure or flow. The process is called either control, limit, or target. When it is closed after delivery of certain volume, we call it volume control. When it is closed after delivery of certain pressure, we call it pressure control. And then when it is closed after delivery of some flow, we call it flow control. As I already discussed, opening of expiratory valve is called cycle. It may be either time or flow. So we can classify the modes of ventilation as per the control. Volume control where trigger is by either time, flow, or pressure. Target is volume and cycle is by time. In pressure control ventilation, trigger is time, flow, or pressure. Target is pressure and cycle is by time. In pressure support, there is no time trigger because patient has to conscious and has to be spontaneously breathing. So trigger is either by flow or pressure. Target is pressure, but cycle is, unlike pressure control, cycle is flow. We also can classify the modes of ventilation as per a sequence. It can be continuous mandatory ventilation. It can be intermittent mandatory ventilation. It can be continuous spontaneous ventilation or CPAP. Target schemes are feedback loop. They may be set point, they may be servo, adaptive control, or intelligence. They are quite complex and it is not the scope of today's class. So I won't discuss it further. So now coming to the indication and contraindication of mechanical ventilation. They are not hard indication or contraindication. Usually we initiate mechanical ventilation in patient with severe type 1 respiratory failure like ARDS, type 2 respiratory failure with carbon dioxide narcosis, increased work of breathing due to any cause, heart failure, pulmonary edema, because positive pressure ventilation decreases the preload and offload the heart. When patient is unconscious and not able to maintain airway, and paralysis of respiratory muscle, for example, Guillain-Barré syndrome. We can initiate mechanical ventilation either by putting an endotracheal tube and securing the airway, or we can start with a mask. When we use mask, airway is not secure. So prerequisite to NIV that patient has to be conscious and should able to protect airways. So what are the advantages of non-invasive ventilation? There we can avoid the complication of an artificial airways. It gives flexibility to the patient. He can sometimes remove the mask, can talk and eat. There is no need of heavy sedation in non-invasive ventilation. It preserves airway defenses, speeds, swallowing and swallowing mechanism. There are some also disadvantages. It can cause gastric distension, pressure lesion over the face, dry nose, irritation, and discomfort. Some patients they have claustrophobia, and there is also sometimes there may be leak around the mask, and it is quite irritating for the patient. While initiating mechanical ventilation, we should think of invasive or non-invasive ventilation. We can try non-invasive ventilation, but we should not try it for a long time. Whenever patient condition does not improve within an hour or so, we should not hesitate to intubate the patient. We should avoid emergency intubation. We should counsel and take consent, because sometimes patient attendant they panic when you discuss about mechanical ventilation with them. We should choose appropriate induction and paralytic agent, because many a time after induction and paralysis, patient has hemodynamic instability. All patients in the ICU should be considered as full stomach, and we should take appropriate prophylaxis for respiration. We should choose ventilator mode as per patient's lung condition. We should monitor loops and scalar, because it helps us for troubleshooting. Also, it gives us early warning sign. It is appropriate to set alarms and backup mode, because many a time you have seen that you have put the patient on volume control mode, and sometimes the tidal volume is not delivered, and you can see high pressure alarm, and when oxygen saturation start falling, you start ventilating the patient with either Bain circuit or a ambu bag. It happens because you sometimes ignore the high pressure alarm limit. Unless you don't increase the high pressure alarm limit, you won't be able to ventilate that patient. You should titrate FiO2 and PEEP to a minimum level to maintain desired SpO2. You should titrate tidal volume and respiratory rate to maintain adequate partial pressure of carbon dioxide. We all know that invasive ventilation increases the chance of ventilator-associated pneumonia. So we should know bed bundles, and we should follow it religiously. Whenever we initiate ventilation, at the same time, we should also think how to wean the patient and when we start weaning the patient. So what to choose? Volume or pressure control? Both are very basic modes of ventilation. In volume control, when delivery of tidal volume is constant in spite of changing lung mechanics, but there may be increased high platelet pressure or peak inspiratory pressure, which can cause lung injury. In volume control, the flow is constant. Sometimes it does not match with the patient demand and cause a patient ventilator asynchrony. Pressure control is a lung protective mode. It also compensates for leak, and it uses deaccelerating flow. So it is better for patient ventilator synchrony. But in pressure control, volume is not constant. Whenever there is decreased compliance, there may be difficult. It can be difficult to deliver adequate tidal volume. So these are the scalars and loop usually we use during mechanical ventilation. The scalars are pressure time scalar. It helps us to identify the different pressure and the cause of increased pressure. The flow time scalar we use to identify auto PEEP, and the volume time we use to identify leak. Pressure volume loop is a very useful to identify the optimum PEEP that should be used. This is a typical pressure time scalar. We can see here three pressure: peak inspiratory pressure, transpiratory pressure, and P plate. Transpiratory pressure is peak inspiratory pressure minus P plate. When transairway pressure is increased but P plate is normal, the cause of increased airway resistance is the obstruction of the airways. And when the trans-airway pressure is normal and the P plate is high, the cause may be either pleural effusion, pneumothorax, etc. Transpulmonary pressure, we already discussed that this is a pressure that is required to ventilate lungs, and it is the formula is P plate minus intrapleural pressure. We don't measure intrapleural pressure directly. We take help of a esophageal probe to calculate transpulmonary pressure. Driving pressure is P plate minus P, and it has been seen that increased driving pressure is associated with increased mortality in patients with ARDS. So whenever you start flying an aeroplane, you should also learn how to land it, because many times winning is more challenging than initiating mechanical ventilation. Again, there is no hard criteria for winning, but you should consider that there should be some recovery of the condition for which he or she was intubated and ventilated. The acid base level should be optimum. Hemodynamics should be stable. The dose of perseverance should not be high, and it should be in a decreasing dose. GCS should be at least more than 8, and he should able to protect his airways. So when the patient meets the winning criteria, we should start spontaneous breathing trial. In spontaneous breathing trial, we support the patient with minimum pressure support of 5 and PEEP of 5, because this pressure is required to negotiate the resistance of the airways. We give spontaneous breathing trial for half an hour to 2 hours, and we don't give this trial more than once in a day. If patient pass spontaneous breathing trial, we consider for extubation. But if the patient does not pass spontaneous breathing trial, we try to evaluate the cause of the failure of the spontaneous breathing trial and try to correct it, and again do the same trial next day. If the patient fails spontaneous breathing trial immediately, and we think that the patient won't be able to win or extubated in short period of time, we consider for tracheostomy. So this is the end of my class. It is not possible to discuss everything about mechanical ventilation in 25 to 30 minutes. So I tried to touch only the basic concepts of mechanical ventilation, and I hope it will help to conceptualize mechanical ventilation when you study further. Thank you.
Thank you, Dr. Saurabh. I know this is a very long and big topic, but you have touched upon the fundamentals of the mechanical ventilation. Fundamental is most important. So if any audience has written any question in the chat box, the organizer can check it.
So no questions as of now.
Any question? Can we take any
no
questions?
Yeah. So right now there are no questions. Maybe towards the end of the session, we can see if there are any questions, we can take them up. Right now there are no questions, sir.
Dr. Saurabh.
Yes, sir.
So I have a question.
Yes, sir.
Suppose if the patient is on TPs and for the weaning trial, and patient is maintaining well with the TPs, how long we can keep the TPs in place?
Sir, this is a very important question, because nowadays people don't favor TPs much. They just keep the patient on the support, and when they do well support, then they extubate. But we have some relevance in TPs, particularly patients who have who have like heart failure and all, because that pressure support we use the for SBT. Also, if you reduce, they may have failure. They may failure. So it is important to try some TP style in some particular patients. So there is no hard and fast time for how long, at least how long we should keep the patient on TP style. There we at least keep 2 to 4 hours. 2 to 4 hours. If patient can tolerate the TP style for 2 to 4 hours, we extubate the patient.
I think the audience is very less in number. I can see 13 are participating. So there will be no question. Let us take the next speaker. Thank you very much, Dr. Saurabh.
Thank you, sir.
Thank you. So the audience platform is different. So these are what you're seeing are the faculty members. The audience,
Okay.
yeah. So we have a lot more students available. Please, sir, continue.
So let me say good morning to Dr. Devatia. I invite you to this symposium organized by Raman Orloya Hospital, New Delhi. Dr. Devatia is very well known to the society. I think all the participants must be knowing about him. He is a new elected president of ISA. So I wish him very good luck, and he will prove his worth, because he is the most known anesthesiologist and researchers in the society. So I invite his professor of anesthesiology in Tata Cancer Hospital, Mumbai. So I invite him to deliver on his topic, newer modes of mechanical ventilation.